So the next speaker will be Pierre Olivier Lang from Switzerland.
Thank you, Mr. Chairman. Ladies and gentlemen, I'm very pleased to be here at Geneva to speak to you about vaccination of the elderly. Apologize me to further delay your lunch break. I try to be on time. The title of the topic is Vaccination of the Elderly, Challenges and Recent Advancement. As you probably already know, the aged population is a very heterogeneous population as regard to different conditions. However, at the same time, aged individuals are much more similar as regard to the increased number of chronic comorbid conditions, increased risk of being malnourished, and increased risk to be immunosenescent. This condition contributes to explain the higher susceptibility to infectious diseases, higher likelihood of being infected by emerging pathogens, and much increased difficulty in dealing with pathogens which were previously overcome. While most of these infections are vaccine preventable, vaccination is often neglected in this population. The two graphics on the screen show you the vaccine coverage rate of the two most important vaccine preventable diseases in the aged population in countries within the European community where data is available. And these coverage rates were below the WHO goals. At the same time, it's collectively believed that immunization is less effective in this population. Indeed, outside a small number of specialist hospital wards, some animal houses, there are no sterile environments around us. And it could be supposed that for living longer, it's needed to deal with a wide range of pathogens, and therefore having construct a strong immune memory. However, the reality is different. With advancing age, the humoral immune system is affected both quantitatively and qualitatively. The cell-mediated immunity is affected both qualitatively and quantitatively. And finally, the innate immune system is affected qualitatively. This is well demonstrated by, for example, the specific cell-mediated immune response following herpes zoster vaccination that decline with advancing age. A reduced humoral immune response to polysaccharide pneumococcal vaccine is observed with advancing age, and this reduction in antibody level correlates with decreased antibody avidity or activity. Defects in cytokine production are strongly associated with poor antibody response to influenza immunization, and this is a functional consequence of impaired Toll-like receptor in the aging innate immune system. Finally, the challenge is here. On one hand, elderly is a population suffer the most from vaccine-preventable diseases, and at the same time, immunization is less effective in this population. The question now is how to solve this challenge. I will propose you 4 options that I detail thereafter. The first one is just do nothing. You know that the world is going gray. In less than 10 years, there will be more individuals over the age of 65 than children under the age of 5, for the first time in the human history. A recent report revealed that the estimated change in total size of the population over 65 in the world between July 2007 and July 2008 was more 10.54 million people, an average of 870,000 each month. And the optimist created by increasing life expectancy is countered by the inextricably link with an ever-increasing susceptibility to a plethora of comorbid conditions. Just take a glass of water, sorry. And the increase in comorbid condition further impedes the immune system by inducing a chronic low-grade inflammation. Finally, this option should not be at all considered. The option number 2, consider the immune response to be gradually getting weaker and provide a stronger stimulus. New vaccine using new license adjuvant has been developed and tested. However, they enhance modestly the vaccine immunogenicity and increase at the same time vaccine reactogenicity that leads to a lower acceptability. Higher vaccine dosage has been developed and tested. They significantly increase immunogenicity, but more on seroconversion rather than seroprotection, and side effects were slightly higher, even if they were well tolerated and transient. Alternative routes were also developed and tested. I didn't speak a lot about intranasal vaccine because it's not recommended over the age of 65. Intradermal vaccine is safety and immunogenic, but not more than the usual intramuscular route. And moreover, all these new vaccines were not for the moment tested against influenza-related infection incidence, influenza-related morbidity, and mortality. My response is why not, but. Why but? But because more antigen, more effective adjuvant, and new delivery routes target only the first step of the immune response to vaccination. At the same time, these options overstimulate the cell pools that are the most reduced during the immunosenescence process, the naive cell pool, both for B and T cell. With not any consideration to the pool, the cell pool, that affect the most the immune response. This pool is represented by the senescent cell. Senescent T cell, for example, exert regulatory role in vivo, and high level of senescent T cell correlate with a poor immune response to vaccination. Option number 3, find out what is the problem and fix it. You know that the failure of the immune system to provide protection is not only related to factors such as comorbid condition, nutritional status, hormonal pathway dysregulation, but also age itself. This age-related increased susceptibility to infection and poorer response to vaccination has been collectively termed immunosenescence. Unfortunately, this decline is not uniform, and some older individuals show less change in their immune system than others at the same age. Therefore, fixing the problem means that we have first to consider who these individuals are, how they might be treated, and when might the treatment start. Who? Due to the complexity of changes giving rise to immunosenescence, it is unlikely that a single predictor could never adequately achieve this ambitious task. Instead, a selection of parameters could provide a guideline for individuals' immunosenescence status. And the most promising target for diagnostic are, for the moment, TREC, BREC, that are potential predictive marker of the resting naive pool, cell pool for B and T cell, and the IED. This is a biomarker of class switch recombination in B cell, switch from EGM response to EGG, acute response to memory response. For the moment, all these markers are at very early stage of development and validation. When? This is my answer. Oh, since thymic involution is a single preceding event in all cases of immunosenescence, different ways have been explored regarding how best to regenerate the peripheral T cell pool and delay or even reverse the senescence. Strategies to reach this goal are usually categorized into the 3 areas of rejuvenation. Restoration is the maintenance of a normal thymic environment by using cytokine, growth hormone, sex steroid, nutrients, supplementation, or growth factor. Replacement is replacing the immune function that was lost by ex vivo generated cells. Naive B cell, for example, from a 3D culture of artificial thymus. And reprogramming the immune system is regulating the telomere length and the stability of the telomere. For the moment, all these strategies have been only achieved in experimental system and with no yet application in clinics. Just an example of restoration of the immune system in old mice. You know that IL-7 is a clinically important growth factor currently used in clinical trials in order to maintain effective activity level into the thymus. And we have recently shown that intratracheal instillation of IL-7 enabling delivery through lungs provide an effective route into the bloodstream and into the tissue. And moreover, comparison with the injected usual route of delivery, administration of IL-7 by pulmonary route improve intrathymic cell development and is not accompanied by any adverse event like inflammatory reaction into the lungs, for example. Option 4, consider the benefits, effects of herd immunity. As you already know, vaccines were primarily designed to directly protect immunized individuals against a target pathogen or infection. However, these vaccine benefits can be extended to close contact, neighbors, or even at the community level. This process is usually termed herd immunity and results in a lower infection rate among unimmunized individuals for different reasons, for infection transmitted only from person to person. A quasi-experimental demonstration of the impact of herd immunity resulted from the retrospective analysis of the Japanese experience with a systematic influenza vaccination of the school children population with an influenza vaccine. The mandatory vaccination program was initiated in 1962, and this program, as you show on the screen, significantly decreased the overall mortality, excess death due to pneumonia and influenza in the overall population, not only in children. Subsequent relaxation of the law due to evident ethical reasons. First in 1987 and its repeal in 1994 were immediately followed by a drop in population immunization rates and a decreasing of the excess mortality in the overall population and mainly in the age population. Another example comes from United States, more recent, when children under the age of 5 were systematically vaccinated with the new 7-valent conjugated pneumococcal vaccine by significantly reducing the carriage of pneumococcus in this population. The beneficial effect of the vaccine were more than double in the overall population and mainly in the 65 and more age population. Similarly, vaccination of health care workers has been suggested as an additional or alternative strategy to lower rates of nosocomial transmission to aged patients. This, moreover, in institutional setting, where is group a population combining the higher risk of vulnerability and the lower vaccine responsiveness. This graphic in red demonstrates you the low vaccine coverage rate among healthcare workers. The rates are just a little bit higher in physician than in nurse. And this data underline the absolute need to target healthcare workers. High coverage rate of influenza immunization, for example, in healthcare workers, in extended care facilities result in following benefit: lower resident mortality, lower risk of influenza-like illness, and lower sick leave from work in staff. However, because most of the vaccine-preventable diseases are not considered to be disabling and life-threatening by healthcare workers, mandatory immunization is the best method for increasing the vaccine coverage rate. My take-home message are finally, vaccine-preventable disease remain a severe burden in the elderly population and moreover in those living in institutional setting. However, elderly population are more prone to be less good responder to vaccination. While more immunogenic vaccines have already been tested and are not effective enough to solve the challenge, strategies for enhancing immunity by rejuvenating the immune system are currently developing and testing. Finally, the current best way to solve the challenge of vaccination of the elderly seems to be based on the herd immunity effect by vaccinated healthcare workers. And mandatory immunization is the best method for increasing this vaccine coverage rate. I thank you for your attention. I wish you a pleasant stay at Geneva and a good rest.
Gaëtan Gavazzi from Grenoble, France. I would like to thank you about your talk, and I have a question about the difference you found in the compliance and the impact of your program. Don't you think that there are some cultural aspects that we have to take into account to prepare such program? Even in China, I saw that there are a very large difference in the impact.
Thank you for your question. May I clarify, is your question why is it that the rate of compliance of our promotion program is different from the others? I think because that might, I confess that that might be a component of how far effect there. But as we all know, compliance rate by checking using the direct observation is still the gold standard, and we are convinced that with time, these staff of the homes, they will be used to a model that they will, once they will adapt it to our presence, they will perform when necessary. And I think the purpose of the promotion program is more on the increase the awareness, because we think maybe we can never strive for 100% in these settings, because as for the long-term care facilities, there are a lot of opportunities which is beyond the usual 5 moments. But still, when the awareness is improved, and when the overall compliance increase, it will help in the overall infection control settings. Yeah.
Okay, Dr. Won, at the end, in the last, one of the last figure, you mentioned the issue of patient participation for the promotion of hygiene. What is your experience in China about this possibility of patient participation specifically? That's a really specific approach of the different countries. It could be working here and not working so much in other countries. What is your experience, please?
It may be something cultural, and because it tends to in Chinese, the culture is they respect the healthcare workers quite a lot. So the opinions of the doctors are less questioned usually, but now it's changing. But for these elderly homes, the residents, they are elderly, and so the concept is still there. So it's quite difficult for them to, initiate a questioning of the practice of the nurse or people who care for them, because there may be some mistrust issues, and but with the younger generation, they are more aware of that, especially when what you have seen after promotion, maybe some of their relatives, their sons and daughters, they may begin to question, So we all have to get prepared. But our feeling is that at this moment, and also we gather from the staff of these homes, from the focus group, that they are not ready. But we will keep that in mind.
So it's the same thing in France and Hong Kong. So that.
And there is another question, yeah?
Sandy Berenger from Australia. Thank you so much for the papers. I'd just like to ask the panel, in light of long-term facilities, healthcare worker immunization is one component, but just like our neonates and looking after the grandmothers and the visitors, or perhaps the parents, the healthcare worker component in long-term facilities may be one aspect. Are we missing out on who actually visits with illness and their immunization status? Because I think that herd immunity, we need to really compare our aged population, I think, like what we would do to our neonate. Is that something that our speakers would like to comment on?
Okay, you want to comment on this issue? Maybe Suzanne.
I think that's an excellent thought. I think the problem is the data only has been looked at in health when nursing homes have had a highly vaccinated healthcare worker population. Have you shown reduction in patient death and illness and complications from flu? The reality is we don't have a lot of control over over the family members. We can certainly exclude people during time of influenza, but there's unfortunately no data except to say the CDC guidelines would say if you're a caretaker of an elderly patient or somebody who's at risk, that you should be vaccinated. And I think I agree, we shouldn't be encouraging that. We're not doing enough of that, but we have no control over them either.
Another remark from Geneva?
I think you're right, and we must extend this recommendation to healthcare workers, to all healthcare providers, including informal carer, family and proxies. I probably highlight healthcare worker situation because healthcare workers are health providers, and if healthcare workers didn't trust on vaccination, they didn't give the vaccine to the patient. It's why.
Thank you so much. So,
I have two questions, one for Suzanne and one for you. The first one is the issue of isolation in single room, which is a very tough issue given that single rooms are not available. And more and more we have residents with are coronized infected with a lot of bugs. So if you look at MRSA, there are papers saying that being in a single room is not being in a single room is a risk factor. Others who are saying it is not. So, and we have KPC now. Do we have solid evidences that we should stick on isolation room when we're... And the question for you was, when did you observe opportunity for hand hygiene? In which moment of the day when they were providing care to individual residents, where they're doing their usual activities, common activities, and so on?
I think, well, certainly having a single room is a luxury that most hospitals and nursing homes can't afford. I think it's an individual decision of each nursing home. For example, in my nursing home, when we looked over a course of 2 years at roommates and we cultured frequently, we saw very limited transmission and very few infections. There are a lot of people, I believe, who were transferred in, who were chronically colonized and would remain so. So I think it depends what problem organism you wish to target. We cohort based on a number of issues. I think there's good evidence that some of the gram-negatives are highly transmissible, and I think we worry about particularly the cefotaxime resistant ESBL producers, whether they have devices in place, surgical infections. So we try to cohort patients together, ideally who have the same organism that we know about, and that's a big if. We take into account whether we're having an outbreak. C. difficile positive patients are a big priority for us, so we tend to cohort them together. VRE's less of an issue. I think it has to be very individual, but it's very problematic. So I think you have to do it in context of what priorities you have set in terms of your problems.
Concerning for the observations, because we have a very good relationship with these homes, so we know the schedule of their care, and then we will tend to space out our observations on different times of the day during different visits, so that we know what their practice is. So it's practically averaging the a whole day of practice. Of course, it's the office hour. It's not nighttime. Nighttime maybe is even less people managing the patients. And that's one question I want to ask Professor Bradley. What is your view on discharging of patients with highly resistant drug resistance, for example, NDM1 from acute care back to the long-term care facilities, especially in developing countries?
It's a very difficult issue, but I think in an era of patient safety and transparency, it's important, if we have knowledge, to let the receiving facility know about it. So at the same time, giving them guidance about appropriate precautions. I think in an era where we have the New Delhi strains and lots of things happening in the community, it's not just going to be from hospitals, and we aren't screening for everything. But I think we still have a duty to let facilities know and to try to educate them when they say, I don't want to take them. Better, that's easier said than done.
Susan, I have another question for you, but it is maybe in the same idea. Several persons mentioned, of course, that long-term care facilities are not isolated. They are working with acute care, ambulatory care, different kind of service in the community. And my question, we are talking about the strategy to improve infection control in this setting, and it's really a need, of course, and a priority and difficult aspect. And do you think that it is maybe possible to really improve if we keep this kind of facility alone? And maybe there should be a regional or local strategy linking the hospital, the facility, ambulatory care, because very often the practicing physicians come into this the nursing home to work. So to try to have a more global approach of safety, of patient safety, which really links these different providers together with the same kind of idea of the quality and safety of the resident. And maybe it's a little bit more difficult than to go inside one particular facility and try to develop something. But, well, that's a suggestion. It's not very innovative, but what do you think about that?
No, I think that's an excellent idea. It gets back to the idea of keeping the healthcare community as a whole informed. For many years, you would hear people say, well, I don't have MRSA, VRE, I don't have this problem. And you know very well that the long-term care facility accepted patients from this hospital, this hospital, this hospital, who had all of those problems. I think we need to be more open that these are realities, and if we know what's going on and we have a network, and again, I think people would say most infection control is local. Mm-hmm. One size doesn't fit all. As Andrew and I have talked about, what happens in Ann Arbor, what happens in Hong Kong are two different things. But I think you have a certain amount of resources, you set your priorities, but I think you have to have some openness about it. Otherwise, but do I have any great magic suggestions other than that? I not really. I'm inclined to agree with you. I think we all have to acknowledge that nursing homes, yes, we have resistance. They get introduced in hospitals, but hospitals introduce resistance into long-term care, and we have to work together.
Okay, thank you so much. Is there some other questions?
Yeah, I just had a comment.
Yes.
Sylvia Munoz-Price from Miami. I just wanted to elaborate a little bit on that topic based on the experience that we had in the greater Chicago area. We had a KPC outbreak in multiple facilities, acute care hospitals, long-term acute care hospitals, and nursing homes. And one of the main barriers that we found, and again, I share with you that it should be a regional approach with a continuum of care, not just in the acute care setting, but in the other settings as well, looking at infection control issues. But something interesting that I saw is one, the infection control interventions were aimed especially in acute care settings. And I remember very much how worried were the infection control medical directors in these facilities. However, when the patients were discharged, they were discharged to either to nursing homes or long-term acute care hospitals. And there was no infection control measures that were being implemented in most of these institutions. The other problem that we faced was that long-term acute care hospitals and nursing homes are private institutions. They're not academic centers. They don't care about publications or the spread of knowledge. And actually, it goes against their benefit for people to know that they have an outbreak going on. So they really, most of them were really not interested in knowing that there was an issue. So I think that having a regional approach to this problem is an excellent idea, but implementing it in real life, especially in the United States, when there are so many economic variables in place, is a challenge.
It's the same thing in many countries. And clearly this difference in management, founding, even thinking between the different sectors of the health system is clearly a difficulty to really build an effective strategy. It is something like we say latent error. It is a latent error to have built our systems in such a way. So maybe if there is no more question from the desk? No, is there?
No.
Okay. So thank you so much for coming, and have a good lunch or a good box. I'm sorry.